that, Dr. Punt, Lydia. Just to say, I think on your brochure, it says the head of clinic department. I must thank them for that promotion. But nevertheless, so I think what we basically end up seeing in general practice and even at the day hospitals, and what we're hoping that the day hospitals can help us out with, is really the long-term side effects of chemotherapy and radiotherapy that we see that needs referral to other clinics other than the oncology clinic. Where do we go? So we'll start off with chemotherapy. And as we said earlier, and lots of the things that I'm going to mention has probably been mentioned earlier, that menopause is one of the things that happen. The hormones get switched off artificially. So one needs to be aware that even though they were treated, and after 5 years, if they're young and they stop the tamoxifen, they'll complain again about, I feel like I'm back on tamoxifen. Menopause will set in naturally again. Infertility was also mentioned, and this is important if it's young people and they come to you and they present, and sometimes they will or will not share the fact that they've been on treatment for breast cancer, and therefore infertility has to be looked at with a view to what they've been on. Weight gain is one of the common things, and this is tamoxifen's sort of big gripe with the patients, commonly on tamoxifen, and we give that for 5 years. So you will see quite a bit of weight gain in the patients, and it becomes counterproductive for the patient who is, we're trying to actually reduce their estrogen level with tamoxifen, and by gaining weight, it increases their fat estrogen level. Fatigue is also very common, and this is one that one has to be careful with, that everything isn't because of cancer. So I normally say when you have a single girl with other siblings, and it's normally change of life. When we look at the thing that everybody speaks about is the chemo brain. I think now after the last 2 years, it was COVID brain. So we talk about brain fog, we talk about brain dysfunction, but normally I put it down as brain function. And one of the factors is really depression. And commonly, you know, we try and explain it away with it's the treatment that we've given them and all that, but very often it's depression, anxiety, and occasionally certain medication they're on. Prednisone is commonly used in our asthma clinics. And just because they have breast cancer or had breast cancer doesn't mean that the asthma goes away. So very often when we see patients, they like to explain everything with the cancer. It's also because it's a very soft clinic to get into. It's very hard for us to deny that it could possibly be the cancer that's occurred. And therefore we get a lot of unnecessary referrals, because the first thing we're going to say, look, with that change in personality, the headaches, probably we're dealing with a brain met. That is a possibility, but I think we need to always exclude the more common things first. Heart problems, a cardiomyopathy, it depends on the treatment they've had with chemo and canocoin radiation, I'll say later, but with chemo particularly, we check the heart function, and then about 2/3, well, after about 3 cycles, we'll recheck the cardiac status to make sure that that heart function hasn't dropped dramatically. Otherwise, chemo can be stopped or changed in those patients. And those are just the names of the drugs that we use. The rare sort of complication long-term for chemotherapy is leukemia. Very rare. I've been there 12 years, haven't seen one or heard of anybody developing it. On the other hand, they may not be referred back to us. So you guys may be seeing it and referred over to hematology, but these are also the chemotherapy drugs that are more likely to cause leukemia. Then always the patients will come to you before treatment. Patients will come and ask a GP or their day hospital or the nurse practitioner for a second opinion on the treatment proposed to them. Treatment isn't started immediately. So the bottom line is we will tell them that the chemotherapy is a little bit sort of, you know, more risky than radiation. The risk increase after 2 years, highest between 5 and 10 years. So nothing gets seen immediately, but the words to them is always the benefits of the chemotherapy would outweigh the long-term side effects. And this is very important because the patients often want to skip this, because again, like I think Liana Wood said earlier, you know, they've spoken to a neighbor, aunt, a sister, and everybody else, lost everything, their hair and everything else. And therefore not wanting chemo. Because I have patients who walk into my room saying, "Doctor, I don't want chemotherapy." They didn't even start to tell me about the cancer, but the first words is, "I don't want chemotherapy." So this is why we need to have sort of an idea of the side effects and basically to convince our patients when it's necessary. So radiotherapy is the other modality. And there we have short-term and long-term side effects, but often skin discoloration. So sometimes you will see it in a lady who's had a wide local excision, scars very neatly done, but you just see this discolored breast and you don't actually realize why it's happening. It's not only the discoloration that occurs, but with it you get skin thickening. So when we blame chemotherapy and radiation with skin thickening, edema, it's also partly because of the surgery, as we saw earlier, removing those nodes affects the drainage of the tissue. So therefore the breast also swells up. And the advice to those patients is to actually sleep with a bra on at night so that the breast remains a little bit elevated above the heart and get the drainage to occur a little bit better. Ribs may fracture, never seen one happen, but it's part of the consent we take for the patients. With the heart, if the radiation is on the left side, we advise them about the possibility of pericarditis. Again, haven't seen one of those. Pneumonitis and lung scarring is a lot more common. That you may see, and patients suddenly getting short of breath, appearing to be asthmatic or pneumonia that's not resolving. If you do the chest x-ray, then you may have the answer there. The swallowing difficulty, not that I've noticed, I think probably more in patients with anxiety, but because when we irradiate the neck area, the supraclavicular area, it is one of the complications that can occur. They can have a little bit of a esophagitis or even a bit of scarring there. So the lymphedema, which commonly will be seen in the general practice and at the day hospital settings, is the swollen arm that can become actually very painful, including causing nerve compression when that happens. So they can sometimes present with carpal tunnel syndrome, as I'll show you later, thoracic outlets. And this is because of the nodes. That is why, as a speaker said earlier, we actually try and cut that down to a single, what we say, a sentinel lymph node biopsy in order to preserve that drainage, because that's one of the common problems we see and actually ends up as being a disability that some people actually gets medically boarded for that. That arm is so swollen. And I've seen this in state cases as well as in private. So it's not, oh, the surgery was badly done or so. It was somebody that was worried about their name and actually it still happens. So this is an unpredictable event. So radiation can cause that as well because it obviously sort of tightens up the skin in that area when they get radiated in that area. The surgery, as well as the fact that women also tend to want to keep working, and then having the arm down and doing lots of work also increases the swelling of that arm. So elevation is how we get past that, and then there is a special lymphedema clinic. So the brachial plexopathy is one thing I like, and I see it very commonly, but unfortunately we sit with a problem, whereas I still can't get hold of the cardiothoracic surgeon. Cardiothoracic surgeons will not see these patients until neurology sees them. Neurology will do nerve conduction studies with a patient lying with the arms on the side. A brachial plexopathy is where the nerves, in this case, we're going to talk about thoracic outlet syndrome, the nerves are squashed between the first rib and the clavicle. So what happens is the lady will tell you when she's hanging up washing, when she wants to tie up her hair, that's when the pain occurs. And often they come to us because they have pain in the breast or pain in the arm. And when you examine them carefully, it's actually the brachial plexus that's involved. It can also get involved at this level in the axillary region, where that will be not only due to the radiation, but also surgery. Long-term surgical scars, there is scarring inside and the tissue sort of gets squashed up. And then with this, it will draw in part of the nerves and they'll have severe pain. And the pain varies. So a very good history will give you obviously the nerve distribution, because the patient will tell you it runs down the back of my arm, front of my arm to the thumb. So it gives you an idea. It's a radicular pain, it's nerve pain. one of the things you will actually see is actually the patient telling you that uh, I can't grip anymore. Okay, they can't grip, and that's basically also the nerves being lost in that hand. So this is actually very common, but I don't know, we have difficulty treating it. I think even if one gets a cardiothoracic surgeon to see them, and the treatment is normally removing the first rib and cutting the scalene muscle to that so that we don't get that area lifting up. It will still be a difficult area because there may be scarring there if there's been radiation to that area, and also surgery. Because that operation is done two ways. One is done via the axilla, which will be a bad idea if the person's had axillary clearance, and the other one is just below the clavicle, make an incision and remove that. This is common. And then again, the other thing we need to look out for is if there's a cancer or even just swelling in the neck. So that can involve the brachial plexus, or just the pressure it will put on can involve that brachial plexus nerves and give you that difficulty. Again, with radiation, we say second cancers, leukemia, and then solid tumors, more in young people, and especially if there is radiation to the supraclavicular fossa. So obviously that involves the neck here, and so it can include the thyroid. Okay, it can just touch on the thyroid and then cause thyroid cancers and scarring. Hoarseness I haven't seen, but it's obviously a possibility if the thyroid is again caught in the radiation field and causing hoarseness there. Again, we have to tell the patient the benefits of radiotherapy outweighs the long-term side effects. So even when we say this to the patients, it doesn't always take away the hurt when it does happen to one of the patients, because it's quite it's quite sad to see them, because there's very little you can offer them. A lot of these side effects I've shown you is very little to offer. Mostly medication, the lymphodemas, a lymphedema clinic, a bit of physiotherapy, massages. Brachial plexopathy is literally medication, Lyrica with its side effects, but very little actual relief. Thank you.